Hey, Dr. O here, and welcome back to Unit 9. This is part 2. We're going to pick up with the kidney's ability to autoregulate as well as interventions of hormonal and neural mechanisms that will actually override that. So let's go ahead and get started. Now, as far as the kidney is concerned, having a constant flow of filtrate is super duper important. In fact, it's better to have a little bit of a flow than moments where there's no flow at all. So a constant glomerular filtration rate is really important to the kidneys. And that's going to be a main motivating factor for the kidney to maintain homeostasis. Now, I did say the kidney to maintain homeostasis because the kidney has the ability, it has a managerial component in what happens within the kidney. Now, that's not the only thing that's going to affect what happens within the kidney, like the kidney's own decision-making process. There's going to be a neurological input that can influence what happens with the kidney, and then there can be hormonal input that can happen with the kidney. So we give names to all of these different inputs as far as homeostatic regulation. And one of them is going to be the intrinsic controls. Intrinsic controls means that the kidney gets to control what's happening in the kidney, also known as renal autoregulation. All right, so this is the goal of what the kidney itself is doing. It's basically trying to maintain local homeostasis through managing its own managerial mechanisms. Now, there are other systemic factors that are going to come in play. These would be our extrinsic controls. And one of these is going to be, like I said, input through the nervous system. Because remember, wherever we have a function in the body, we typically have a neural input that can override normal mechanisms that might be running that system in case we have an emergency need. So that's what we're going to see is the case with our nervous system. Now, we also have a longer managerial component that typically comes through the endocrine system, through our hormones. And so this is going to be a second mechanism outside of the kidney that can influence control over the kidney's desire to maintain homeostasis. Now, what that means is that the kidney will often have one goal in mind, which is to maintain glomerular filtration rate. But the nervous system and the endocrine system are going to have a different goal. And their goal is to basically keep the rest of the body alive. The kidney's looking out for the kidney, but the nervous system and the endocrine system are looking out for the entire body. And sometimes those two objectives might be at a little bit of might be at odds with each other. But if we are overriding what the kidney's doing for us, it's typically because we're in an emergency situation, like we're bleeding to death, something like that. So let's take a little bit deeper dive into this on the next few slides. Now, before we get too far along in that, I want to talk about a structure that we see here on this slide because it's going to play a big role in the kidney, regulating the kidney. So let's get oriented with what we know. So we know that we're looking at the renal corpuscle right here. We've got our capsule, Bowman's capsule, going around our little glomerular tuft. We have our afferent arteriole feeding it and our efferent arteriole draining it. We have our proximal convoluted tubule. And then I'm going to point out this right here. This is either a component of the distal convoluted tubule or the very end of the nephron loop. It's going to be somewhere in there, and you will read different sources that will say that this is distal convoluted tubule, or other sources that will say this is the end of the loop of Henle. So somewhere in that transition, we're going to see this. So what this means is that here we have our renal corpuscle, we have our proximal convoluted tubule. Proximal convoluted tubule went off and did its thing. We had the loop coming down, and then it comes back up, and it's going to make a pass, and it's going to make a pass right here between the two arterioles. And that's going to be an important feature. Now, why is that? It has to do with this special little cluster of cells right here, in part. These are found within the wall of the distal convoluted tubule or the ascending loop of Henle. And this is known as the macula densa. Now, the word macula means spot, and densa means dense. So there's this cluster of cells all jammed in here together, and they act like a little chemistry lab. And what they're measuring is they're measuring the concentration of sodium chloride in the filtrate as it's getting ready to leave the nephron. Because remember, this portion of the tubule, this portion right here of this tubule, is either the ascending loop of Henle or the very first part of the distal convoluted tubule. So we still have a little bit of a ways to go to act on this filtrate if we need to fine tune it. But at this point, most of the work should have been done. So if we have a super high concentration of sodium chloride ions in here, that tells us one thing. And if we have a low concentration of sodium chloride ions in here, that tells us something else. So this is an important little patch of cells right here, this macula densa. Now, whatever these little macula densa chemistry cells figure out, they're going to tell this little cluster of cells right here, known as the extraglomerular mesangial cells. So these are mesangial cells that are found outside of the glomerulus. There are some that are found inside the glomerulus. Those are the cells that are doing the little contractile business of the glomerulus, making its surface area shrink. That's the intraglomerular mesangial cells. But these extraglomerular mesangial cells are going to act a little bit like neurons. And they're going to convey the message that is sent by the macula densa over to the cells that are lining mostly the afferent arteriole, could be also the efferent arteriole. But these special cells that are lining the afferent arteriole are called granular cells. Sometimes they're called the JC cells, the juxtaglomerular complex cells. But I think on my slides are called the granular cells. So the granular cells are going to receive a message from the mesangial cells that something is happening within here regarding the within the distal convoluted tubule / distal end of the loop of Henle, that there's something going on with our sodium chloride concentration and you need to do something. That's basically how that works. So the juxtaglomerular complex, which is what I just went through, these three structures right here outside of the glomerulus, but next to it, that's what juxta means, next to it. These are going to be a major player in renal autoregulation. So the juxtaglomerular complex is a major player in renal autoregulation. So the kidney being able to regulate itself is relying upon these three structures to basically help it figure out what's going on. So let's take a look at that. So on this slide, I go through the role of each one of those players and just kind of lay it out for you. So like I said, the macula densa are the chemoreceptors, and they're detecting the sodium chloride content in the filtrate as it's getting ready to do its last leg of its journey through the tubule system. Then we have, I'm going to skip down here to the extraglomerular mesangial cells, which are located between the two arterioles of the that are feeding the renal corpuscle and the tubule cells, mostly of the macula densa, and their job is to pass signals between the macula densa and the granular cells. And then the granular cells, also known as the juxtaglomerular cells or the JG cells, their job is basically to respond to that information, and they are a smooth muscle cell, and they will either contract or relax depending upon what information is coming from the macula densa. So depending upon the information from the macula densa, it can cause the smooth muscle to contract and restrict the flow of blood into the renal corpuscle, or it can cause the smooth muscle to relax and allow more blood into the renal corpuscle. And we will look at that in detail in a few slides. All right. The other thing that can happen is that whatever message is being created by the macula densa and conveyed to the granular cells by the extraglomerular mesangial cells, it might also trigger the granular cells to release the enzyme renin. So it's these smooth muscle cells with their mechanoreceptors and their special secretory granules that are capable of releasing renin, which will then trigger the whole renin, angiotensin, aldosterone system. And we'll look at that too, in case you don't remember. So let's start off by talking about the kidney's ability to autoregulate, the intrinsic controls. So the kidney wants to maintain a nearly constant glomerular filtration rate. It seems like the delicate structures of the nephron are best supported when there's a little bit of flow going through there all the time, and that there's damage that gets sustained when the flow stops. All right, so the kidney functions best when the mean arterial pressure in the body is between 80 and 180 millimeters of mercury. So when we have reasonably normal blood pressure in the body, then glomerular filtration rate is going to remain pretty constant. If we end up with a super high blood pressure or super low blood pressure, the renal autoregulatory mechanisms don't function very well, if at all. All right. So what are these functions? Well, there's basically two types of control mechanisms that the kidney can exert in order to regulate itself. One of them is called a myogenic mechanism. Myo means muscle, and genic means starting with. So starting with the muscle, we'll take a look at what muscle we're talking about there. Probably something to do with that afferent arteriole. And then we have the tubuloglomerular feedback mechanism. And I'll tell you already, that's going to involve those cells of the macula densa and what's coming through the tubule system. All right, so let's get into the detail about these two things. So the myogenic mechanism is going to have to do with the smooth muscle that lines the afferent and maybe to a lesser degree the efferent arterioles that are feeding the glomerulus. All right, so the local smooth muscle of these two vessels are going to contract when they get stretched. And why would they get stretched? Because there's a lot of blood pressure coming its way. So it's like the afferent arteriole senses an extra wave of blood getting ready to move through it because there's mechanoreceptors in there. They're going to trigger this stretch mechanism. And the cells are going to recognize that. The smooth muscle cells of the afferent artery are going to recognize that, and so they're going to contract a little bit because they don't want that big wave of blood moving in there, because at number one, it can disrupt the glomerular filtration rate. It might cause it to spike. Don't want that to happen. And the other reason why is that if it allows a big wave of blood to move through, it can damage the glomerulus. All right, so the mechanoreceptors and the afferent arteriole particularly, maybe even the efferent arteriole to a degree, have the capacity to detect stretch and shut down in order to restrict the blood flow into the glomerulus, more or less to protect the glomerulus and also to preserve a steady glomerular filtration rate. So you think about that big wave of blood coming in, like a tsunami of blood coming that way. The afferent arteriole figures out it's coming and it shuts down. Doesn't want what's on the other side, aka the glomerulus, to be damaged by that big tsunami of blood coming its way. Now the opposite is true. If the blood pressure were to suddenly drop. So the afferent arteriole detects that, wait a minute, there's not the usual amount of stretch here, and I see just a trickle of blood coming my way. So I'm actually going to relax my tone and expand my space to allow whatever blood is coming my way to come in unimpeded. So the afferent arterioles will be triggered to shut down if a big tsunami wave of blood's coming its way, or it will be triggered to open up if that blood that's coming its way is something less than, something more like a trickle. All right, so that's our myogenic mechanism. So the ability of the smooth muscle of the afferent arteriole to a lesser degree, playing a role in managing what makes its way, what blood makes its way into the glomerulus in order to protect the glomerulus and to help maintain a steady glomerular filtration rate. Now the other mechanism is the tubuloglomerular feedback mechanism, and this is going to involve the macula densa and its analysis of the filtrate that's coming through. Now, this is what we call a flow-dependent mechanism. So what does that mean? Well, it means that depending upon the filtration rate, uh, that's going to play a role in how effective the movement of solutes is going to be on that filtrate. So if the filtrate is moving through too quickly through the tubule system, like we're moving too much fluid into the renal corpuscle, and we've got a high flow of fluid going through the tubule system, then that means that our cells are not having enough time to work that filtrate and move solutes out. And you can end up with a you can end up with a higher concentration of solutes in there as a result. So it's like, because remember, whatever's spilling out of the blood has to be worked on by the cells of the proximal convoluted tubule and the loop of Henle in order to do the big sweeps out. But if that blood is flying through there at 50 miles an hour, then it might not have time to do that. If the blood's going through there at a normal rate, let's say normal is 30 miles an hour, then it has time to do that. And so what ends up coming to that point where it's the filtrate's reaching the macula densa is going to be fluid that has had a lot of the particulate matter, a lot of particulates moved out of it and back into the blood. So the macula densa knows how many particles should be in there. And when that particle number is too high, the concentration of solutes is too high, then that means, as far as the nephron is concerned, that there's too much fluid going through. The glomerular filtration rate is too high. So that's the message that it's sending to the extramesangial cells, and then the extramesangial cells will tell the granular cells, you're allowing too much fluid in because we've got a filtration rate that's too high. The proximal convoluted tubule and the loop of Henle don't have enough time to move the solutes out, so we need to slow that rate down from 55 to 30. Now the opposite is true. If the glomerular filtration rate is too low, so what happens in that scenario is that now we've gone from maybe our normal 35 miles an hour or 30 miles an hour of filtration rate flowing through our tubule system. Maybe we dropped it down to 15 miles per hour. And now the blood's just like really leisurely taking blood. Now the filtrate is leisurely just strolling through the tubule system, just lingering a little too long, and the cells are like, okay, we'll move everything out. Yeah, you're hanging out. We'll just keep moving stuff out as long as you're here. We're just going to keep moving the particles out, so that by the time that fluid makes its way over through the proximal convoluted tubule and the loop of Henle, and it gets over to the macula densa of the juxtaglomerular apparatus, our filtration, our filtrate sodium chloride concentration is too low because all of the solutes have been pulled out. And in this case, the macula densa is going to say to the extramesangial cells, extraglomerular mesangial cells, they need to speed it up. They need to speed it up because there should be a little bit more sodium chloride in here than what I see. So that means that the filtrate's just lollygagging around in the tubule system. We need to speed it up. And so that message gets taken over to the smooth muscle cells, the granular cells of the afferent arteriole, and then they will relax and allow more filtrate to be created, more blood to come into the glomerulus and more filtrate to be created. So these are the two mechanisms that the kidney is using to control what's happening in the kidney. When it comes to the neural and the hormonal mechanisms, as I said previously, the whole purpose of these two mechanisms is to ensure systemic blood pressure. And these control mechanisms will override the kidney's ability to self-regulate, but only in the case of blood pressure needing to be increased, which is achieved through increasing blood volume. So usually the kidney does a good job of taking care of things, and it kind of needs to know what needs to happen. And in supporting itself, it has a tendency to support the body. But if, for example, you were to sustain a big blood loss, like maybe through an injury, then there would need to be some other mechanism that would kick in, because the kidney would try to preserve itself, and the body is trying to preserve blood flow to the heart and the brain. So let's take a look at these. Now we've talked about neural overriding, override of intrinsic systems before, and in all of these scenarios it's going to be the sympathetic nervous system. So usually when we're in some sort of a fight or flight scenario trying to survive, do we see the nervous system overriding what might be happening locally. So under normal conditions, the kidney is going to self-regulate. So normally the renal blood vessels are going to be dilated, everything's going to be great. But under abnormal conditions, such as super low blood pressure, which means very low extracellular fluid, low blood volume, all of those sorts of things, then we're going to see the sympathetic nervous system kicking in and overriding what the kidney is doing. So what does that mean? Well, it means that we're going to have norepinephrine being released by the sympathetic nervous system, epinephrine being released by the adrenal medulla, and these two circulating hormones are going to cause systemic vasoconstriction. And what we're trying to do there is increase blood pressure. Now that also means that the renal blood vessels might constrict as well. All right, and when that happens, that's going to decrease glomerular filtration rate. So less blood is getting into the glomerulus, which means that we're going to be reducing the amount of filtrate that we can create. And what ends up happening is that systemically, blood volume gets maintained and blood pressure gets increased. So basically, we've reduced what's happening in the nephron. We've reduced the amount of fluid that is coming out of the blood and into filtrate, and that's helping keep our blood volume and consequently our blood pressure up. So that's the whole function of the sympathetic nervous system, causing vasoconstriction, which will help maintain blood pressure. Now, the big hormone mechanism here starts with renin, and we're going to talk about that as well. But we're going to also look at what can trigger the release of renin from the granular cells in the nephron. So there are three pathways to stimulate the release of renin. Number one is that you can have the sympathetic nervous system saying, oh dear, we've lost blood pressure and we want to hedge all of our bets, so we're going to have renin be released, and that's going to help us pull out fluid from any filtrate that's already been made and then return that to the blood and keep our blood pressure up. That's number one. Number two could be stimulation by the macula densa cells when the filtrate sodium chloride concentration is too low. So that's another mechanism that can trigger the release of renin. So when the macula densa is looking at glomerular filtration rate and saying, "Hey, wait a minute, it's too low. We need to like change things around here and get the filtrate rate back up," then that can trigger the release of renin. And then also, if we've got reduced stretch on the granular cells, that can also be created by low blood pressure, as can a low filtration rate, which leads to low sodium chloride concentrations. I didn't specify that, but we will talk about all that. So yeah, reduced stretch on the granular cells, that typically means that we've got low blood pressure, and that will also trigger the release of renin. So let's actually look at all of these and what's going on. So let's start off by talking about what the renin angiotensin aldosterone mechanism or system really is. So we first off have a low blood pressure scenario, and that's going to be the trigger for the granular cells to release renin. Renin is an enzyme. Sometimes it's called a hormone, but it's really an enzyme, and it gets released into the bloodstream, and it's going to circulate until it finds a intermediary or an almost ready to go molecule called angiotensinogen, which is made in the liver. So this is always circulating in the blood. But when it gets acted on by renin, it's going to get converted into something known as angiotensin 1. Now this is still not biologically active. There's an additional bit of work that needs to be done on this. So angiotensin 1 is going to circulate around in the bloodstream until it makes its way over to the lungs, where there is a membrane-bound enzyme there in the pulmonary capillary alveolar membrane that is going to convert angiotensin 1 into angiotensin 2. Now it's ready to go. So what is angiotensin 2 going to do for us? Well, angiotensin 2 is going to cause vasoconstriction. That's convenient. It's also going to cause the release of antidiuretic hormone from the posterior pituitary. What does that do? Antidiuretic hormone. Well, a diuretic makes you pee. So antidiuretic means that it makes you not pee. And the way that we not pee is we don't make filtrate. So whatever filtrate we make, maybe we're even returning it to the blood. So that's a possibility with ADH. Aldosterone does the same thing. Different mechanism, but basically aldosterone is pulling fluid out of filtrate and returning it to the blood. So these two hormones are going to go to work on the nephron and pull fluid out of filtrate and return it to the blood. If we return fluid to the blood, that increases blood volume. Increased blood volume means increased blood pressure. Now, as if that isn't enough, angiotensin 2 is going to go up to the hypothalamus and trigger the thirst receptors to make you go drink some fluid to help replace the fluid that you might be losing as a result of whatever is creating this low blood pressure. So if we look at this whole mechanism, this renin, angiotensin, aldosterone system is all designed to increase blood pressure. So it gets triggered when blood pressure drops. So let's talk about what's happening in the tubule system. Now we already know that the tubular reabsorption and tubular secretion are from the perspective of the bloodstream. So things that are reabsorbed are, the tubular reabsorption is actually stuff going back into the bloodstream, and tubular secretion means that things are being released from the bloodstream going into filtrate. All right, so that's the first thing that we need to know. Now with regard to reabsorption, we know that in the very first part of the tubule system, in the proximal convoluted tubule system, we're going to absorb about 90% of whatever spilled out into the renal corpuscle. So that's what we mean by reabsorption is going to quickly reclaim most of the contents and return it back to the blood. So what's going on with that? Well, almost all of the organic nutrients are going to be pulled out of the filtrate. Water and many of our ions are going to be pulled out of the filtrate too, although these are going to be hormonally regulated towards the end of the tubule system. So, but we can see mass movement of water and ions at the very beginning in the proximal convoluted tubule system. So that's not an uncommon substance to have being moved out of filtrate and back into the blood. Now, when we talk about the process of reabsorption, it can either be an active process, such as through active transport, or it can be a passive process, basically looking at things like osmosis or diffusion. So there's a number of mechanisms that the tubule cells are going to be utilizing in order to move substances around, and that's true for reabsorption as well. So we know that the proximal convoluted tubule is going to be the site of most of our reabsorption, and we know that because of the presence of the microvilli on the apical surface of these cells. So what are we going to be pulling out of our filtrate? Well, we're going to be pulling all of our nutrients out, like our glucose and our amino acids. All of those get reabsorbed. About 65% of our sodium ions are going to get reabsorbed, and of course we know that wherever we move sodium, water is going to follow it. So we're going to be moving a large amount of our sodium and a whole lot of the water out of that filtrate. Many ions are going to also follow because whenever we move sodium around, it will create like an electrochemical gradient, and so a lot of other things are going to tag along and go with it. Things like maybe glucose can travel with that. Also, some of the negatively charged ions are going to travel with that, so that's not an uncommon thing to see. If you see mass movement of sodium, you're also going to see movement of other things being shuttled around as well. Almost all of the uric acid is going to be moved out of the proximal convoluted tubule at this point, and about half of the urea, but that's going to actually get returned back to the tubule system a little bit later on. So there's a lot of stuff that's being moved out of filtrate and back into the blood in this proximal convoluted tubule. So what are the big things we want you to know about? I would know that roughly 65% of the sodium and a whole lot of water, and glucose and amino acids. Those would be the big things that I would definitely remember are being moved across at this point. All right, so once our filtrate leaves the proximal convoluted tubule, it's going to go into the nephron loop. And we know that something different is happening in each of the two branches of this loop. In the descending limb and the ascending limb, different stuff is happening. So the descending is called the thin branch and the ascending is called the thick branch. And of course, we know form follows function, so that gives us a clue that different things are happening here. So what are these things that are happening? Well, in the descending loop, in the thin portion of the loop, what we're going to see is that water can leave the filtrate, but not solutes. Now, in the ascending branch of the loop, the opposite is true. Water is going to be stuck inside. It can't leave, but we're going to allow solutes to leave. Solute of interest here is going to be sodium. So in the thick segment of the loop, we've got different mechanisms by which we're going to move sodium out. So we have sodium potassium symporters, and we've got sodium hydrogen antiporters. These are just different mechanisms by which we can move ions around without affecting charge balance too much. And basically what we're going to be doing is we're going to be moving that sodium out of the filtrate into the cell of the tubule, and then ultimately that cell is going to move that ion outside of the cell into that space between the tubule and the peritubular capillary. Now there's a reason for this, and we didn't know this reason for quite some time, but we now know the reason, and we're going to talk about the reason why this happens in just a little bit. So just tuck that away. For now, what you need to know is that water can leave the descending limb of the loop of Henle, but solutes can. And on the ascending loop, the opposite is true. Now the solutes can leave, but the water can't. Now, once our filtrate is done being worked on by the loop of Henle, it's going to enter into the distal convoluted tubule and then ultimately into the collecting duct. Now, at this point, we're not doing mass movement of ions or fluids out of the tubule. Instead, we're doing a very selective process that's going to be regulated by hormones. And the two hormones of interest are antidiuretic hormone and aldosterone. Now, what are these two hormones doing? What are they physically doing at the level of the nephron? That's what we're going to learn. So let's take a look at antidiuretic hormone for starters. So we know that antidiuretic hormone is going to be released by the posterior pituitary, right? And what it's going to do is it's going to enter the circulation, and when it makes its way over to the distal convoluted tubule and the collecting duct, it's going to trigger those principal cells. Remember those guys? Talked about those a little bit earlier, principal cells. It's going to trigger the principal cells, particularly of the collecting duct, to insert a special temporary water channel into the tubule. And the special water channel is called an aquaporin. And what that's going to do is it's going to cause water to leave the filtrate and make its way into the interstitial space between the tubule and the peritubular capillary, and then cause that water to be taken up by the capillary and be returned to the blood supply. So I'll say that again. So antidiuretic hormone is largely going to have its effect on on some cells that are in the collecting duct. And what it does is it triggers those cells to pull out its special temporary water pore and insert it so that water can be shuttled, so that fluid rather can be shuttled out of filtrate, out of the tubule system, out of the filtrate, and make its way into the interstitial space and ultimately back into the capillary and back into the bloodstream. And in that way, we reduce the amount of filtrate we make, which means antidiuretic, which means we're not going to pee as often or as much because we just shuttled out a bunch of water and returned it to the bloodstream. So let's take a look at what aldosterone is doing for us. Now, aldosterone is going to exert a lot of its effects on the distal convoluted tubule, although it can also have some effect on some of the cells, also the principal cells of the collecting duct. But largely we can think of aldosterone as affecting the distal convoluted tubule. Now, what's it going to do? Well, it doesn't involve the aquaporins, I'll tell you that. That is the purview of the antidiuretic hormone. What happens here is aldosterone is going to promote the cells of the distal convoluted tubule to make and produce and make functional sodium-potassium pumps. So aldosterone triggers the cells of the distal convoluted tubule to fire up its sodium-potassium pumps. Now, why is that? Because aldosterone is all about moving sodium around. It's going to move sodium out of the filtrate and return it to the blood supply, and the only reason we do that is because we know that in moving sodium we're going to move water at the same time. And our job is to get blood pressure back up, which means we have to get blood volume back up, and the way that we do that is to get water back into the bloodstream, and the way that we do that is to move sodium into the bloodstream. And so aldosterone triggers the cells of the distal convoluted tubule to fire up sodium-potassium pumps to move sodium out of the filtrate and back into the bloodstream, knowing that water is going to follow it. Now, what this means is, as far as our sodium population, is that we moved about 2/3 of the sodium that was in filtrate out of filtrate and back into the blood in the proximal convoluted tubule. When we got into the ascending loop of Henle, we gave sodium another big opportunity to move out of filtrate, which means ultimately it's going to make its way back into the bloodstream. And so what little sodium is left can be acted on by aldosterone. But most of our sodium has been returned to the body. So very little sodium actually leaves the body. And if we actually lost more than 2% of our sodium, that's incompatible with life. So we need aldosterone in order to stay alive. So that's what aldosterone is doing, firing up sodium-potassium pumps in the distal convoluted tubule and moving that last little bit of sodium into the bloodstream and in order to get the water to follow it. All right, so let's talk a little bit about secretion. Now in secretion, this is when the blood is going to be moving stuff out of the bloodstream in order to get it back into filtrate. So we could think of it as reabsorption in reverse. And the thing is that most of the secretion is going to be occurring almost exclusively at the proximal convoluted tubule. Now, there still could be some possibility of that happening elsewhere, but the biggest amount of it's going to be happening at the proximal convoluted tubule. So keep in mind, we have this capillary network that goes around the tubule system. And the reason why is because we do have this interplay of things moving in and out of the tubule system. And when things get moved out of the tubule system, it has to go somewhere, so it's going to go back into the blood supply. But then we also want there to be that ability for the blood supply to say, you know what, I really don't want this in here, and have it move, have the blood supply move things out of the blood so that it can make its way back in to filtrate. So it's a two-way street here. All right, so that's why we have this. But most of the secretion, most of the stuff that the blood's going to get rid of is going to happen near the proximal convoluted tubule. So what's going to get moved out? Well, it could be things like potassium, hydrogen ions, ammonia ions, if there should happen to be any left, creatinine, various organic acids and bases, things like that. So there's movement of those sorts of things. I'm going to present a slide here shortly that shows you what sorts of things are moving around and where. So just wait until we get to the pictures. It'll make a lot more sense. So why do we even have secretion? Why do we even allow the blood an opportunity to eliminate things from it? I mean, wasn't that what filtration was for? Over there in the renal corpuscle? Yeah, that's true. That's exactly what it's for. But there's a possibility that everything that should have spilled out didn't. So this is like another redundancy built into the system, just in case everything that should have gotten out didn't get out. So we have secretion. All right, so it's important for getting rid of things like drugs or various metabolites that didn't get spilled out into the renal corpuscle. It helps us eliminate undesirable substances that might have been passively reabsorbed, because remember, we are still reabsorbing urea and uric acid at the proximal convoluted tubule. So we need a mechanism by which we can eliminate these from the blood while the blood's right there next to a nephron. It can also help rid the body of extra potassium, which is actually an effect of aldosterone, and we'll talk a little bit about that. And it helps control blood pH by altering the amounts of hydrogen ions or even bicarbonate ions that might be destined to be in urine. So that's why we have this additional opportunity to move things out of the blood and to filtrate. All right, so this is a really great image that shows you what is being reabsorbed back into the blood and what is being released from the blood and where. So our big purple square, surprise, surprise, here we are at the proximal convoluted tubule, and look at all the things that are being moved back into the bloodstream. And then look at what's being moved out of the blood back into filtrate. Of course, it's going to include urea, uric acid, creatinine, some other nasty stuff we don't want, like ammonia. So big movements happening at the proximal convoluted tubule. When we look at what's happening in the descending limb, loop of Henle, water's moving out here. We look at what's happening in the ascending loop. We've got largely sodium moving out, but we could have some other ions moving out as well. We have the opportunity for some urea to also sneak back in, but we didn't make a big deal about that. Here at the distal convoluted tubule, our big thing is sodium. We could have some other things coming out here, but the big one is sodium thanks to the effects of aldosterone. We could also have a few things sneaking back in. And then in the collecting duct, pretty much we can allow some stuff out, but nothing's really going to make its way in. And the fact that we're allowing stuff out is going to be largely the effect of ADH. I know I say aldosterone here, but it's largely ADH. So for my Bio 1300 students, we can think of distal convoluted tubule being associated with aldosterone and collecting duct as being associated with ADH. So let's talk about passive movement of substances here in the tubule system. So let's talk about the passive movement of water in particular. So let's get you oriented with this image. So over here on the far left of our image, this is inside of our tubule. This darker tan structure here is a cell of the tubule. And it looks like we're proximal convoluted tubule because we have all these microvilli here. And whatever gets moved out of the tubule system is going to first enter into an interstitial area, and then it'll make its way into a capillary, the peritubular capillary. All right, so this is the area that we're talking about. So what we see happening in this particular image is we see that we have the movement of hydrogen ions happening in an opposite flow of sodium ions, so there's that sort of movement. We also have a, uh, a chemical gradient that gets created by moving sodium. We can also tag other particles along with it, like chloride ions or calcium ions or other substances like glucose and phosphates. They can tag along with the movement of sodium as sodium is being shuttled around. And you'll notice that we're moving stuff out of filtrate inside of these cuboid cells. And then from here, the cuboid cells are going to move those substances across its other membrane, the other side, called the basolateral side of the cell, into the interstitial space for the purpose of getting it to go into the bloodstream. And in this little image right here, they're showing that they're actually having to use a sodium-potassium pump to move these two substances across. And remember, the only reason why we would use a great deal of energy to move something is because we're moving it against a concentration gradient. When we talk about water movement, there's a couple of terms you need to know, and one of them is obligatory water reabsorption. And basically what this means is that whenever we move sodium, water is obliged to follow. That's basically what we mean. That's what we mean by obligatory. Wherever we move sodium, water is going to follow it. Water is obliged to follow. So that's just kind of a rule that Mother Nature has set up in the body. And so she's given the special power of sodium to be in charge of water movement. We don't ever directly move water around in the body, but we do move sodium, knowing full well that water will follow. That is our obligatory water movement. All right, the other one is facultative water absorption or water movement. And this one involves the use of those aquaporins. So the faculty at work here is the aquaporin. So facultative water reabsorption happens by way of the aquaporins, so special temporary pores that can be inserted or removed thanks to the principal cells acting under the influence of ADH. Or we could have obligatory water movement, which is the movement of sodium, and water is obliged to follow, which could be happening under the effects of aldosterone, or it could just be happening under the effects of normal movement due to concentration gradients, diffusion, things like that. Because that's what's happening at the proximal convoluted tubule. There's no pumps really happening there. Now, it says here that aquaporins are always present in the proximal convoluted tubule, and that is in part what is aiding the movement, the mass movement of substances out of the proximal convoluted tubule. That is true. But then we selectively insert and remove aquaporins in the collecting duct in order to regulate and fine-tune the movement of water around in the body. Now, it shouldn't come as a surprise that sodium is going to be the most abundant positively charged ion that we're going to find in filtrate. And that's because sodium's kind of everywhere. It's going to be a large player in all extracellular fluid, including what we see here in the filtrate. And the way that we move sodium around is through active transport. And the way that happens is with the sodium-potassium pump. Now, sodium is going to be swept from the interstitial fluid. So once we move our sodium, let's back up for a second. Once sodium is moved out of the tubule into the tubule cell, that cuboid cell, it will then be moved into the interstitial space. And once sodium is there, it's going to be swept by bulk flow into the peritubular capillary. So now it's entered into the bloodstream and fluid's going to go with it. Water's going to go with it. Now, sodium reabsorption by primary active transport creates a secondary effect, which means that a lot of other things are going to be attached to sodium as the sodium gets moved around. So sodium gets moved around by the active mechanism of pumping it through the sodium potassium pumps, and in the process it creates this chemoelectrical gradient that a lot of other molecules are going to latch onto and be shuttled around as well. So Mother Nature doesn't like to waste too many steps when she does something, and this is one of those mechanisms. So we can use sodium to transport, certainly sodium, but we can also use it to transport water because we know that water follows sodium around. We can also use it to transport chloride ions because chloride will follow sodium around. Because it creates this electrochemical gradient, it can also move things like glucose and amino acids around, as well as other ions like potassium, calcium, and maybe even some hydrogen ions. So it can end up being utilized to move a whole lot of other things around. And those whole lot of other things that get moved are traveling in what we would call a secondary active transport system. So not the intended target of the motion, but they take advantage of what's happening and then off they go. So the secondary transport mechanism is based upon that electrochemical gradient that gets created when sodium moves around. So the sodium potassium pumps basically give the push that's needed to move other solutes as it's in the process of moving sodium around. So a lot of our organic nutrients get absorbed by this electrochemical gradient that gets created. They get moved around by this secondary active transport mechanism. We could even call that a co-transport mechanism. So like I said on the previous slide, things like glucose and amino acids, various ions that I started to list, things like calcium can be shuttled around this way, as well as many of our vitamins. So what this image is trying to explain is this concept that I was just talking about. So here to the far left, we have filtrate in the tubule lumen, and we have all the different ways that things can pass from in here to the bloodstream. So we can have co-transport mechanisms where sodium gets pumped into the cell, and it carries with it things like amino acids, ions, vitamins, glucose, and then from there we can use sodium potassium pumps to further move sodium into the interstitial space, because remember there's already a whole lot of sodium here. This is an extracellular area, and there could already be a great deal of sodium here, which is why we have to utilize energy to move more sodium into this space. And then we're also shuttling potassium around at the same time. So there's that. We can move water around through aquaporins. Some ions and urea can actually slip in between the cells of the peritubular capillaries and get into the interstitial space. We have different ion channels that we can allow things to slip around. And then, of course, many of our lipids, if we should happen to have any that end up here, can slip past the cell membranes and make their way into the interstitial space. So this is how we can have this activity of reabsorption and secretion happening, is because we have all these different mechanisms that our peritubular capillary cells can utilize to shuttle things around in order to get them out of filtrate and into the peritubular capillary, or how to get them out of the interstitial fluid once they've left the peritubular capillary and then get them into the filtrate. And another image basically talking about reabsorption and secretion, the interplay between the peritubular capillary and the tubule system. And this is information that we've already seen as far as what gets moved out of the filtrate and back into the blood, what gets moved out of the blood and back into filtrate, and the different regions of the tubule system where things are happening. So that's what all is happening with this. So just another another image to kind of bring all of this into view and reiterate everything we've already said. Now, the management of the bicarbonate ion is going to be really important because the bicarbonate ion is important for buffering the blood. Now, it's very possible that we could have hydrogen ions end up in our filtrate, and then that's going to be evacuated out of the body in the urine. And so this is one of the ways that the kidneys manage long-term acid-base balance, because remember, every time we drop carbon dioxide into the blood has enzymes that are going to take carbon dioxide and water and turn it into carbonic acid. Now, carbonic acid means that we're going to have a hydrogen ion liberated, but we're also going to have this bicarbonate ion liberated as well. But the body would rather have these guys floating around than those hydrogen ions. So we get rid of the hydrogen ions that get formed when we create the bicarbonate ion. We get rid of these in the kidneys. All right, that's a possibility. So that is one mechanism. Now, the other mechanism that gets involved in the bicarbonate management system is that the kidneys are going to try to hang on to this bicarbonate ion and return it to the blood, so that make sure that there are plenty of these hanging around in the bloodstream in order to join up with any hydrogen ions that might be being released in the bloodstream and thereby create some stability for our pH. All right, so what's going on with all of that? Well, in the proximal convoluted tubule, we can't simply move the bicarbonate ion across the cells of the tubule system and return it to the blood. So we actually have to do some chemistry to get it in the right form so that we can ultimately move this ion around. So what happens is that in the proximal convoluted tubule, we're going to take that bicarbonate ion, we're going to join it back up with a hydrogen ion, and we're going to go ahead and form our carbonic acid. Now, there is an enzyme that is going to convert our carbonic acid molecule back into a water molecule and a carbon dioxide. And both of these are going to easily move out of filtrate that's in the proximal convoluted tubule into the cell of the proximal convoluted tubule. Now, once water and carbon dioxide get moved into the cell of the proximal convoluted tubule, there is an enzyme that is going to convert carbon dioxide back into the bicarbonate ion, and then that gets co-transported along with sodium into the interstitial space, and then it will ultimately re-enter the blood. Now, I know that's a mouthful, so of course I've got an image that's going to go into this level of detail. So here's an image that takes you through the steps that are involved in taking our bicarbonate ion and converting it into a bicarbonate ion that can be taken up by the bloodstream. So it all starts here in the lumen of our tubule. So here we're in the lumen, here's the cell of our proximal convoluted tubule. Blue space is the interstitial fluid between the tubule and then ultimately the capillary to the far right here. So it starts here in the lumen of the proximal convoluted tubule, and we have a bicarbonate ion, and we might have just recently moved this hydrogen ion back into the lumen because we're using it as an antiporter for our sodium that we wanted to shuttle around for some reason. So here it is, and hydrogen ions and these bicarbonate ions will spontaneously rejoin to form this carbonic acid molecule. Now, there are enzymes in the proximal convoluted tubule that are going to cause the carbonic acid to get cleaved apart and create a water molecule and carbon dioxide. Now, the water molecule can be shuttled inside of our cell, or maybe it stays in the filtrate. Either one of those is a possibility, but we've created our carbon dioxide molecule, and carbon dioxide can be shuttled inside of the cell, and that's going to be an important component here. So once carbon dioxide gets shuttled inside of the cell of our proximal convoluted tubule, there could be a water molecule in there. Maybe it brought its partner with it, but however that works out, there's going to be this water molecule available to bind with this carbon dioxide molecule. And when it does, it's going to form a molecule of carbonic acid. And the thing about carbonic acid is that it will spontaneously cast off a hydrogen ion and a bicarbonate ion. And now we've essentially taken our bicarbonate ion and had to kind of twist it around a few times, but we've got this bicarbonate ion that can now travel outside of the cell through some sort of a pump. It can just follow sodium into the interstitial space and then be shuttled back into the bloodstream. So the bottom line with this is that we can't move the bicarbonate ion directly into the cell so that it can be moved into the interstitial space and ultimately be taken up by the bloodstream. We have to convert it back into carbonic acid and then take carbonic acid and turn it into a couple of things that can be moved inside of this cell, of the proximal convoluted tubule, and then do a little bit more work converting it back into the bicarbonate ion and then shuttle it out. So we know that micturition is also called urination. We can even call it voiding. There's a whole lot of euphemisms for this activity, but we're going to keep it to these two right here, urination and micturition. Sometimes I do say voiding. All right, so what has to happen in order for us to be able to void? Well, you have to have the contraction of the wall of the bladder, the detrusor muscle, and that happens through autonomic nervous system input. You have to have the opening of the internal urethral sphincter, and that also happens through autonomic input. And then you have to have opening of the external urethral sphincter, and that happens through somatic nervous system input. This is the only thing that we have conscious control over. The other two happen with the autonomic input. And once all three of these things are in place, then we can relieve ourselves of the fluid in the bladder. Now, those three steps we just got through talking about are what happen when we're potty trained. But what if we're not potty trained? What if we're an infant? Well, then all of that gets managed through a reflex. So there is such a thing as reflexive urination. So what happens in this scenario is that you have distension of the bladder, and that's going to activate some stretch receptors. And these stretch receptors, once activated, causes excitation of parasympathetic neurons in the reflex center of the sacral region of the spinal cord. And then this is going to lead to contraction of the detrusor muscle and the opening of the internal sphincter. And it'll also create inhibition of the somatic pathways to the external sphincter. And then that combination of activities is what's going to lead to urination. So when a baby urinates, this is what is happening. The baby's not, willing it to happen. He's not, it's not that a baby can hold its urine, because it can't. It doesn't have that level of awareness. So it's all managed as a series of spinal reflexes, or as a reflex arc, we could say. Now, the reason why we don't see infants having the ability to regulate when they void is because the pons hasn't developed the control centers, at least not initially, and we don't see those control centers maturing until the person is between 2 and 3 years of age. And so it just happens to be that's when about the time we start potty training is about the age of 2. Now there is a pontine storage center that inhibits micturition, and what it's doing is inhibiting the parasympathetic pathways and exciting the sympathetic and maybe even some sympathetic efferent pathways. So that's the storage center. That's what's helping us hold it. Now we also have micturition centers in the pontine area, in the pons, that promotes voiding. And what happens here is just the opposite. Instead of inhibiting parasympathetic pathways, we're going to excite them. And instead of exciting our sympathetic pathways, we're going to inhibit them. So the storage centers and the micturition centers will act just the opposite of each other once the pons has evolved enough to have that sort of control over micturition. So here is a pathway that kind of goes through the act of urination and the flow chart and all the things that are involved in it, whether it's a spinal reflex or whether it's higher brain functions. And so I'll leave you to review all of that. This is just, we've already covered this information, which is why I don't feel the need to go through the flow chart. So that's on you. Pause the video if you must. So I'm going to touch on a few homeostatic imbalances as it pertains to the urinary system. And um, in this part of all the lectures, I usually include a slide on each one of the topics that we want the Galen students to know. And but I encourage you to do a little bit more reading on it. So this is just to kind of get you started, but I would say go to the textbook, look to the modules, and fill in any blanks that might be here. All right, let's talk about urinary incontinence. Basically, this is when you have an inability to effectively hold your urine. And in adults, this is usually caused by weakening of the pelvic floor muscles. So what we see are a couple of different types of incontinence. We have stress incontinence, which is when you lose control or you have some leakage of the urine because of an increase in the intra-abdominal force. So this is what we see when you leak a little bit of urine, if you laugh or cough or sneeze, something like that. Something that causes an increase in your intra-abdominal pressure. Then we have overflow incontinence, which is when urine will dribble out when the bladder overfills. So again, you've lost the ability to hold in your urine because your external sphincter isn't strong enough to keep things tightly inside. Urinary tract infections are not an uncommon feature, and in almost 80% of the cases of UTI, the offending bacteria is going to be E. coli. And where does E. coli come from? It can come from the bowel. Women are at greater risk of UTIs than men are, and why is that? Well, it's because women have a shorter urethra than men do, which means that whatever bacterial agent is causing the UTI has a much shorter passageway in order to get to the bladder in women than it does in men. Um, so what does it look like? What does a patient with a UTI look like? Well, they have an urge to urinate, and it may be productive or not. There can be burning and pain when urinating. The color of the urine can be it can be pink. It can be sort of a dark amber, orangey color. It could even be red, depending on how much blood is in there. And it can be strong smelling. Now, there are other things that are going to make your urine smell strong, such as asparagus and maybe some other things in your diet. But if your strong smelling urine is coupled with one or two of these other symptoms, then chances are really good that you've got a UTI. And the way that we treat UTI is with antibiotics. Now, how do we prevent UTIs? Well, number one, drink a lot of water. Keep the whole system flushed. Because remember, we've got that little trigone, which could be seen as a breeding ground for bacteria. And if you keep it flushed out, then it prevents the bacteria from having an opportunity to get a foothold. It prevents a bacterial foothold from taking place. So drink a lot of water. The other thing, this is true for women, is wipe from front to back. So take your toilet paper, wipe from front to back. Now, why is that important? Well, we already said that most UTIs are from E. coli, which means that if you are moving that toilet paper from the posterior part of your perineal region forward, then you could be dragging with it some of the E. coli from your rectum and then introducing it to your urethra. Don't want to do that. So if you're suffering from recurrent bladder infections, change your hygiene habits. All right. Another thing could be the type of birth control that you're using. So changing birth control method can also play a role, particularly for women. So if you're a woman and you're using something like spermicides or unlubricated condoms or other mechanical devices, that can increase the likelihood of a UTI. Now, I've done some research, personally, I've done some research on this, and I didn't see any studies that supported an increase in UTIs in oral contraception. It all appeared to be things associated with the use of spermicides, condoms, and diaphragms. Wow, kidney stones, those will make for a bad day. Kidney stones are also called renal calculi, and these are hard deposits of minerals and salts that accumulate and form in the kidneys. And they're caused by diet, which could also be associated with excess weight, not drinking enough fluid, which is leading to that concentrated urine. There could be other medical conditions that could lead to this. Also, the amount of minerals in your water supply can make a difference. So the thing is that symptoms of kidney stones don't develop until the kidney stone starts to move. And when that's the case, there's a lot of pain, nausea, maybe vomiting. You're going to have a lot of pink and bright red colored urine. You might be spiking a fever. And depending on how bad things are, it could actually get really bad. It can create secondary problems like blood poisoning and all kinds of fun stuff like that. But if we just leave the chat to kidney stones, yeah, that's going to pretty much drive you into the doctor's office, more likely into the ER. Just be honest with it. It's really bad pain. So how do we treat a kidney stone? Well, it really depends upon the size of the stone that you have. If the stone is small enough, you might be able to pass it on your own. If it's large, then it might need to be broken up and into smaller pieces and moved out that way. The other possibility is a surgical procedure where they go in with a little grasping device and pluck it out. So it depends. If you have a stone that started to move, for example, and got lodged somewhere in the ureter, then they could go in through your urethra and the bladder and then go up into the ureter and with this little grasping tool and pluck it out. Or they could try to break it up with sound waves. So there's some options with getting the kidney stones to move, but in my opinion, after having had one, I would say drink a lot of water. Just drink a lot of water. Don't even run the risk of developing one. Now, renal failure is another possibility. This is also called end-stage renal disease, and this is when the kidneys can no longer filter the blood, and that's going to be a huge problem because we need the kidneys to do that for us. So, diseases that slow blood flow can lead to kidney damage and failure. So this is coming back to that concept where the kidneys really want a steady rate of glomerular filtration production, and when we start to shut that down through slowing down the blood flow to the kidney, it can create that damage. So it's kind of that concept there where the kidney is trying to preserve the kidney because it understands that it can get damaged rather easily. So what can do this? Well, heart attacks can do this. Heart disease can do this. Liver failure can do this because we funnel a lot of blood through the liver as well. And if the liver's not functioning very well, then that can be a problem. Burns can do this because you can lose a lot of fluid through burns. Severe dehydration, lose a lot of fluid that way. Cancer could create a scenario where it's slowing the flow of blood to the kidney, depending upon where the tumor is located. Kidney stones can also do this. Infection. So there's a number of things that can lead to challenges to the kidneys, damage the filtration unit, and then we end up with renal disease. So what does it look like? Well, you're going to retain a lot of fluid because we're not going to have the mechanism to move additional fluid out of the blood. You can have reduced urine output because the fluid's staying in the blood. You can feel weak. You can end up with an irregular heartbeat. You can end up with seizures and coma. So renal failure is it's a tough way to go. Yeah, and a lot of it has to do with the imbalances in the chemistry and the imbalances in the fluid that get created as a result of losing that kidney function. So when you have a patient who has renal failure, what do? Well, you first of all want to treat the underlying cause of the failure. So that might be a fluid balance issue. It might be a medication to help control potassium and calcium levels. And it might be doing something like dialysis to remove the toxins. So depending upon the treatment is going to depend upon what the patient has going on. Prevention is going to be the preventative approach is going to be to maintain your health overall. So reducing your usage of over-the-counter pain medications, because those can be kind of hard on the kidney. It can be managing any sort of chronic kidney conditions that maybe you have or maybe that you know might be part of your heredity. Drinking a lot of water, preventing the kidney stones, protecting your liver. There's a whole lot of ways to prevent renal failure, and they all are hinged upon maintaining overall health. And with that, we are done. Thanks for watching.